corneal tissues in an eye bank following HCRP and voluntary eye donation, which was a retrospective study. So eye donation in India may be voluntary donation or hospital retrieval based. In voluntary eye donation, it is a traditional one, which is based on family motivation towards eye donation. And in hospital cornea retrieval program, there is direct motivation of the family of the deceased, and it is known to provide access to young and high quality corneal tissues. Hence, the objective of this study was to assess the donor corneal tissue quality in an eye bank at a tertiary care hospital in North India following HCRP. The aim of this study was to compare the quality and utilization of donor corneal tissues obtained through HCRP and voluntary eye donation. The objectives of this study were to compare the donor profile of HCRP and voluntary eye donation, and to compare the quality and utilization of corneal tissue in HCRP and voluntary eye donation. This was a retrospective study where records were analyzed from August 2019 till November 2023 after institutional ethical approval. Donor demographics such as age, gender, cause of death, death to preservation time, lens status, endothelial cell density, slit lamp assessments, and donor corneal tissue utilizations were noted. A comparative analysis was conducted to assess the quality of donor corneal tissue between HCRP MLC, HCRP non-MLC, and voluntary eye donation groups. Categorical variables were represented as numbers and percentages, and quantitative data as mean plus minus standard deviation, and median with 25th and 75th percentiles as interquartile range. Non-parametric tests were used for non-normally distributed data. Qualitative variables were compared using the chi-square test with Fisher's exact test employed for values below 5. So coming to the results, we collected a total of 746 corneas from 374 donors, and one donor from each of the HCRP and voluntary group were monocular. So we collected a total of 547 corneas through HCRP retrieval and 199 corneas through voluntary eye donation. Amongst the HCRP corneas collected, 348 were MLC cases and 199 were non-MLC cases. So coming to the further analysis, we see that the most younger donors were available in the HCRP MLC group. Maximum number of females were present in the voluntary eye donation group. On the other hand, maximum number of males were present in the HCRP MLC group. The cause of death in the HCRP MLC group was road traffic accident. In the HCRP non-MLC group, it was mainly septic shock, and in the voluntary eye donation group, it was mainly natural. Death to preservation time was found to be maximum in the HCRP MLC group, and most of the phakic patients were found in the HCRP MLC group. Epithelial defect was maximum seen in the corneas collected through HCRP MLC cases. Stromal edema, arcus, descemet membrane folds, stress lines were maximum in the voluntary eye donation group. Now we can see from here that the endothelial cell density was maximum in the corneas collected through HCRP MLC, and corneal utilization rate was also even higher in the HCRP MLC group. Now coming to the discussion, here we have compared our study with two other similar studies, one done by Namrata Sharma et al. And the other by Rashmi et al. The sample size in our study was 746 corneas in a duration of 51 months. N. Sharma et al. Collected 1014 corneas in a duration of 14 months, and Rashmi et al. Collected 985 corneas in a duration of 12 months. The mean age along the HCRP and VED groups were almost similar in Rashmi et al. And in our study, and maximum number of males was found in the HCRP group across all the three studies, and in the voluntary eye donation group, our study found that males and females were almost similar, but the other studies found that males were maximum. The cause of death in our study and Rashmi et al. Study in HCRP group was road traffic accident, and in the voluntary eye donation it was natural in our study and cardiovascular in the other two studies. The maximum death to preservation time is seen in HCRP group across all the three studies. The maximum number of phakic patients were seen across HCRP group across all the three studies, and pseudophakic patients were more amongst the voluntary eye donation group. As we can see in all the three studies, the better quality of endothelial cells was found in the HCRP group only, and hence for optical purposes, maximum corneas were utilized. Those corneas were utilized which were collected through HCRP, and for therapeutic purposes, the corneas collected from voluntary eye donation were utilized mainly. So coming to the conclusion, the hospital retrieval program is the need of the hour, as it has the potential to enhance the availability of high quality corneal tissues and improves corneal tissue utilization rate. And this initiative holds a promise in to help in eradication of corneal blindness in our country. Thank you.
So, what different you get from these two studies, Namrata et al. And something?
Others two studies, basically they did not compare between MLC and non-MLC cases.
Okay.
Like they basically compared hospital collection retrieval and voluntary eye donation. But we did a further analysis between MLC and non-MLC cases in the hospital.
While collecting corneas from MLC cases, usually what protocols are done?
Procedure.
From MLC cases.
Yeah, MLC cases, like we first need to coordinate with the forensic department, ma'am. They need to clear, and the investigating police officer. Usually we have a police jockey at our institute only, so we take clearance from them.
Okay, thank you. Are you ready? So, the presenting author is Jessica.
Very good afternoon. It's not moving. My paper is about early diagnosis and intervention in subclinical keratoconus, which is we are conquering cone in children. Keratoconus, as we all know, it is an inflammatory, bilateral, asymmetrical, progressive thinning and ectasia of the cornea, causing irregular astigmatism and defective vision. Corneal ectasia in children less than 18 years is the pediatric keratoconus. Incidence and prevalence. When we see, it is 1 in 2,000 in adults, whereas in children it is 1 in 625. What is pondering? What is more important in pediatric KC is that it has a very rapid progression. Also, it has many association like ocular and systemic, especially VKC, and presentation is at very advanced stage. Much more important thing is that it affects the quality of the life. Aim of the study is to determine the pediatric prevalence of keratoconus and to provide intervention to prevent the progression. Materials and methods. It was a retrospective analysis in children of age 5 to 16 years, done over a period of 10 years. It was approved by ethical committee. Chi-square test was used for statistical analysis. Criteria, patients around the age of 5 to 16 years with astigmatism of more than 1.5 diopter cylinder who were uncorrectable with the cylinder power, and those who had normal anterior posterior segment were included. And those with active VKC, corneal scarring, strabismus, retinal pathology, cataract or any previous ocular surgery were not included in the study. After the initial assessment, according to the steep K values, they were segregated into 3 groups. Group A included patients who had a K reading of less than 47 diopter, B between 47 diopters to 53 diopters, Group C more than 53 diopters. Results. Out of 584 eyes, 36 eyes, which is 6% had keratoconus. Of them, 5 eyes, which is 13% required collagen cross-linking. In group B, out of 428 eyes, 78 eyes, which is 18%, and 20 eyes, which is 25% required C3R. In group C, among 153 eyes, 105 eyes had keratoconus, and 48 eyes required C3R at the time of diagnosis. Prevalence of keratoconus in all the groups like group A, group B and group C were statistically significant. Also, the need for collagen cross-linking also in group A, B and C was significant. These are the results. Summary, in total of 116 eyes, 209 eyes are required keratoconus. I mean, were diagnosed to have keratoconus. This group A had 6%, group B 18, group C 68. And from 209 eyes, 73 eyes required collagen cross-linking, which is group A 13%, group B 25, and group C 45%. After 2 years of follow-up post collagen cross-linking, 77 eyes showed flattening, 18% eyes showed stable K value, and 3% showed progression. Also, the mean K value changed from 56.34 to 54.75. So take home message here is that screening of children with astigmatism more than 1.5 or a steeper care reading is important. Treatment is very time sensitive. A corneal collagen cross-linking remains the cornerstone to halt the progression. Stringent management specific to the disease state is very important. Thank you.
So, when do you recommend CPR surgery in pediatric kids?
Sir, when the presenting thickness itself is very less, sir, and they're showing progression of more than 1 in care reading in 6 months or a thickness of more than 5% loss in 6 months, we are recommending C3R, sir. Even the visual Snellen line loss of 1 or 2 lines, we are recommending C3R. In patients who are not having active VKC, sir, if they're having VKC, we are trying to treat them, making the eyes quiet, then only we are planning for the CH, sir.
You have done topography.
Yes,
So,
sir.
Any qualitative or quantitative data you are included in this study? Anything you are diagnosed on the basis of keratometry
The
only?
pathfinder value, sir.
Okay.
Based on the pathfinder KCN pattern, if present or not. How much percentage of pathfinder is showing KCN pattern?
And the progressors at the end of 2 years, and then
Yes,
they
ma'am.
were
Even
belonging to
after,
which group?
even after,
To which group did they belong to? That you had not, I guess. They belong to the C group.
both, mostly C group, ma'am, also in A and B also, ma'am, they had uncontrollable VKC, ma'am. Even after supratarsal card, they had VKC. Thank you.
Next, next speaker is Dr. Garima Rath.
Yes, yes. This one first one.
Good afternoon, everyone. Today, I'll be presenting a paper on factors influencing corneal haze post-collagen cross-linking in keratoconus treatment. This is my financial disclosure. So, as we all know, keratoconus is a progressive corneal associated with corneal protrusion and thinning that leads to irregular myopic astigmatism. It is usually bilateral but asymmetric, presenting to us with mostly during the second and third decade. And for mild to moderate keratoconus cases, we usually prefer doing collagen cross-linking using riboflavin and UVA light. The most common complication post-collagen cross-linking is corneal haze formation that leads to increased backward scattering of light, increased corneal densitometry, which also leads to temporary suboptimal visual acuity. Now, about corneal haze post-cross-linking, we can assess this qualitatively using slit lamp biomicroscope, confocal microscopy, as well as anterior segment ASOCT. Quantitatively, it can be assessed using sign plug photography. In few studies, they have shown using in vivo confocal microscopy that there is increase in the density of extracellular fibrillar matrix. Also, there is reduction in the density of anterior keratocytes, which leads to the hyperreflective phenomenon in the treated zone. In pentacam, corneal densitometry is analyzed using first the machine locates the corneal apex, and then it analyzes an area around the diameter of 12 mm, which is further subdivided into 4 zones that are central 2 mm, 2 to 6 mm, 6 to 10 mm, and then 10 to 12 mm respectively. And the output is given in terms of gray scale unit, which measures the minimum light scatter and value set as 0. That is the maximum transparency, and maximum light scatter leveling it as 100, which suggests minimum transparency. So the main objective, the primary objective of our study was to determine the factor influencing corneal haze formation following C3R, also to address the association of pachymetry, keratometry and their changes associated with haze formation. Secondary objective was to analyze the relationship between corneal haze and visual outcome. So this was a prospective observational study which was done over a period of 24 months that include 84 keratoconic eye Preoperative assessment was done by measurement of uncorrected and best corrected visual acuity, slit lamp examination, and then pentacam was done to measure the K1, K2, K max, K mean, central corneal thickness, thinnest point, densitometry values, ART max, and progression index. And then patients underwent the cross-linking procedure, and post-procedure visual acuity was again measured, the uncorrected, best corrected, with slit lamp examination for measurement of corneal haze and its grading. Follow-up visit was done in 1, 3, 6 and 12 months respectively, and all the factors were reassessed. So coming to the results, the mean age in our study was around 19 years and 8 months. Majority that belonged to the age group of 16 to 20 years, followed by 21 to 25 years. In our study, there were 48 females and 36 males. The mean baseline UCVA improved by 1 Snellen line at the end of 1 month, plateaued over 3 months, further improved at the 6 months, and then plateaued. The mean baseline BCVA remained unchanged. Coming to the K mean and K max reading, which peaked at 1 month post CXCL with subsequent dip, and the thinnest corneal thickness largely reduced until the first 3 months, yet showing an increased trend from the 6 month onwards. Based on slit lamp grading of corneal haze at 1 month, nearly 98% of the patient had grade 1 haze, which remained relatively stable at the end of 3 months and 6 months. By the end of 1 year, nearly 53% had complete resolution of haze. Coming to ART max, at 1 month median ART max decreased to 116 when compared with the baseline value of 174. At 3 months, it further decreased to 101. At 6 months and 12 months, it progressively increased to median value of 120 and 137 respectively, and all these changes were statistically significant with a p-value of less than 0.01%. Now, association of anterior layer thickness, densitometry values, there was significant association in all 1 month, 3 months, 6 months and 12 months. In central layer densitometry, compared to the baseline, the changes were seen in every layer, every zone except for the 6 to 10 mm zone. In case of posterior layer, significant changes were seen except for 6 to 10 mm zone in 6 and 12 months. So the main discussion from the study that we got is K mean and K max reading had similar pattern that peaked at 1 month. The increase in K max value 1 to 3 months after CXCL was attributed to disorganized stroma. In contrast with the other studies, our studies show a significant change in densitometry values, especially in the anterior layer of the cornea that peaked at 1 month. So based on the existing literature, most common influencing factor listed for the development of haze include pre-op K max, thinnest corneal thickness and young age of the patient. And in our study, preoperative ART max had significant association with persistence at 6 months. The strength of our study was, this was the first cross-sectional study done in South India in patient undergoing C3 or post-keratoconus. It is an objective and reliable method that we used was pentacam to assess corneal densitometry. Also, our study may help us to predict the treatment success and expectations post C3R. The limitation was that the period was just 1 year, so we cannot exclude the possibility that the corneal haze might continue to evolve beyond the time frame. There was no comparison or control group. Densitometry measurements with sign plug camera has its own limitation. These are my references. Thank you.
When you measured the haze, you found that it was increasing or stable? You said it's stable.
Yes, ma'am.
But you said it might evolve, you said in the last slide.
What we measured, ma'am, in 84 keratoconus eyes, mostly patient has had grade 1 haze by the end of 3 months.
So what functional disability did it create? Was there glare? Was there was diminution of vision?
There was diminution of vision, ma'am.
Did you check glare and other functional visual disability?
No, ma'am. We just checked the uncorrected and best vision.
How much line difference was there?
There was 1 Snellen line of difference, ma'am, which was found in 1 month, which plateaued over a period of 3 months. Then again at 6 months, there was difference of 1 Snellen line, which again plateaued at the end of 1 year, ma'am. Sir, mostly in our study, we saw the apical keratoconus more in our patients. And other ocular conditions, sir, VKC is the most common ocular condition that is associated with what we see associated with keratoconus. Down syndrome. Yes, sir.
What are the indications of collagen cross-linking in keratoconus? At what stage you will do keratoconus?
Ma'am, whenever we see any progression in the patient which previously has presented, we have done pentacam and we see progression. Also, if uh, the patient present to us in a certain age group, we usually don't see progression beyond the age of around 26 to 30 years. So when the patient present to us in the age where we expect progression, we usually take them up for collagen cross-linking. Also, when there are obvious parameters in the pentacam which are showing that the patient is keratogenic, then we usually take them up.
What are the contraindications?
So, okay, so. Hmm. Got it. Okay, sir. Okay, sir. Okay, sir.
Thank you, Dr. Garma.
Yes,
Due to
thank you,
paucity of time, we will move to next speaker. Conventional C3R versus accelerated C3R in progressive keratoconus. Dr. Madhusmita.
A very good afternoon to all of you. Today I shall be discussing about the conventional corneal collagen cross-linking versus the accelerated corneal collagen cross-linking. It's a comparative study we have done. So as you all of know, the keratoconus is keratomens cornea and the conus mens cones. It's a non-inflammatory bilateral disease which is characterized by the progressive thinning and apical protrusion of the cornea, which cause severe reduction in the vision. So there are several risk factors which also we found in our patients, the genetic and the environmental risk factors. Apart from that, the first degree relatives and twins of the keratoconic patients. The other syndromes like Sir mentioned, the Leber's congenital amaurosis, the Down syndrome, the Ehlers-Danlos and the Marfan syndromes which can be associated with keratoconus, the eye rubbing and the allergic eye disease. Apart from this, the geographical areas with plenty of sunshine and hot climate patients are more vulnerable. And the ultraviolet light induced oxidative stress also has a role in the keratoconus. So the patients present with the refractive abnormalities, the blurring of vision, the increased light sensitivity, the ghost images and diplopia. And on examination we can see like image A, the thinning of the apex of the cornea, followed by the image B which is showing the Munchausen signs. So it's a downward, on downward gaze we see the indentation of the lower eyelid. Apart from that, in the image C, you can see the parastromal scar, and in the image D, we can see there is a Fleischer ring, which is the deposition of the iron around the base of the cone. Image E depicting the Vox stria, which is the breaks in the Descemet's membrane, and image F denoting a acute case of corneal hydrops. So our study was a hospital-based randomized double-blind and a comparative study which was done over a period of 2 months, out of which the 18 months we collected the data and period of data analysis was the 6 month. So our primary objective in the study was to study the effect of the CXL on corneal curvature and the corneal thickness in both the procedures and changes in the topometric indices and the endothelial cell density after the C3R procedure. Also, we studied in this study the effect of CXL on the best corrected visual acuity in the spherical and the astigmatic powers. So in our study, we have tried to assess the clinical outcome of novel minimally invasive procedure of CXL and AXL, and we have compared on the basis of the parameters like K1, K2, Kmax, the pentacam indices like IHT, ISB and IVA, the thinnest and the central corneal thickness, the endothelial cell density, and secondarily we also compared the best corrected visual acuity in both the cases and acceptance of the sphere and the cylinder on refraction pre and post CXL procedures. So here in our study we have taken patients aged between 14 to 32 years of age where the corneal pachymetry shown the thickness of the cornea was more than 400 micrometer, and the documented keratoconus progression was there. That is at least one of the following clinical signs in the last 1 year period. There is increase in at least 1 diopter of maximum keratometry findings, a 2% decrease in the central corneal thickness, and an increase in corneal cylinder of at least 1 diopter. We excluded the patient where we found corneal hydrops, so severe dry eye, or the patient refused to give consent apical corneal scarring was there or any active infection was present. So after initial evaluation of the visual acuity, slit lamp examination and detailed fundus examination, when you saw the findings in the slit lamp, and we proceeded with the investigations like pentacam, where both the Berlin numbers were enhanced ectasia and the 4-map display was shown. We followed in these patients doing after prepping the eye. We performed in 27 patients. We total took 54 patients, out of which in 27 patients we did conventional method and 27 patients we did accelerated method. So these patients were allotted in 2 groups, and the pre-CXL findings and the all the parameters findings at 1 month, 3 month, and 6 month were taken into consideration. And the results are presented in terms of the pre-operative baseline, 1, 3, and 6 month post-operative period, and the changes were noted. Like these are the baseline pre-operative finding, all the indices. The BCVA, the accepted acceptance sphere and cylinder, K1, K2, Kmax, and all the pentacam indices. In the BCVA and the spherical and the cylindrical, we did not find any significant difference between the 2 groups. Although we found in both the methods there was a significant difference. There is significant improvement in the best corrected visual acuity in the spherical and the cylindrical power. In the thinnest and corneal thickness, central corneal thickness, and the intraocular pressure, we did not find any difference between the 2 procedures. But in the K1, K2, Kmax also we could not find any difference. But when we measured the topographic indices in the pentacam indices, in all IVA, ISB, and IHD, we definitely found more improvement in cases of accelerated collagen cross-linking. So to conclude, these 2 treatments seem to be effective conservative management option in halting the disease. So both the procedure can significantly improve the morbidity and can be considered as effective and minimally invasive treatment. But definitely patient will be prefer more the accelerated C3R procedure because it takes less time and it's a better patient compliance and reduced exposure time, and there is also lower infection risk because of the reduced time of performing the surgeries. Thank you.
What is new in the study is, I think these studies, this type of studies I've done previously.
Pardon me, sir.
What is new in this study?
So this study we found definitely there is no significant difference in other indices, but in the pentacam indices we found it's better to perform the accelerated C3R because the difference in improvement of the pentacam indices like the index of the height decentration, the surface variance, it was better in the accelerated group.
So other references you have included?
Sorry, sir?
References?
Yes, sir. Yes,
this
sir.
type of studies?
Yeah, this type of studies has been done, sir, but they did not find any much difference. Other studies have found in the there is definitely improvement in the astigmatic acceptance of the astigmatic power, which is better in accelerated. But the pentacam indices, only the index of height decentration I have found in the studies, literature studies. ISB and IHD, we found that it is definitely better in the accelerated group.
Have you compared your results with other studies?
Yes, yes, ma'am. Okay, I have not mentioned here, yeah, but it's it has been compared with 10 literature studies, ma'am, and in 3 studies we have found there is definitely there is improvement in the accelerator, and it's better to perform the accelerator. Sir, 6-month follow-up period you have done, sir, after performing the surgery, which is definitely less. Yes, sir. Follow-up is short.
What was was this a retrospective study?
No, ma'am, it was a prospective study.
So how did you calculate the sample size and whether it was randomized or it was based on the patient's, I mean, what were the confounding factors in this case?
It was a randomized one. It was a randomized studies, and as we wanted to compare these 2 procedures, so when the patients came, like we had already when we did not have the accelerated C3R machine, so when we had the conventional, the CXL machine, so we performed those patients in the CXL group, and in between after 10 procedures.
So that is not randomized, that's convenient sampling, it's called. Classically it's called convenient sampling. So
Ma'am, I was going to about that because we did not include, because total we had 74 patients, but as there was no machine, so we did not include those patients where there is only conventional was done because we did not have the facility. So after that we randomized. Thank you.
Next is, please come, Dr. Cyprus. Sarda, Dr. Sipra Sarda.
She is not there.
Next is there. Next is Dr. Jyoti. Dr. Jyoti. Next is Dr. Siddharam Jantil.
Good afternoon. This is a case report. Moxifloxacin induced corneal toxicity, a case report. 58-year male presented with defective vision and progressive whitish discoloration in left eye for since 2 weeks, increasing the severity from the past 3 days. Not associated with pain or redness. No history of headache or photophobia. No history of diplopia, floater and flashes. Patient underwent left eye cataract surgery 4 weeks back. Did not follow up after post-operative review. He was prescribed topical dexamethasone, moxifloxacin combination 2 hourly and calcium chloride, potassium iodide and sodium chloride in combination as eye drops for 1 month. Vision, right eye was normal. Left eye vision post-op 3, 6/9 with pinhole 6/6. But when you come for follow-up after 1 month, around 31 days, it becomes hand movements. When you examine this patient, there is, you can see, there is crystalline, whitish crystalline deposits in the epithelium and up to mid-stromal lesion. And there is, when you do staining, there is fluorescent staining is taking place around 7 millimeters. When you do when you have done the investigation, serum calcium, potassium normal, corneal scraping done for KOH and gram stain, it's become negative. This we clinically diagnosed as a moxifloxacin-induced keratopathy. Management, what we have done is stop the moxifloxacin eye drops and started lubricating drops and tobramycin eye drops. And therapeutic screening was unsuccessful. Status quo we maintained for 2 months for follow-up, but there is no improvement in this patient. Then later planned penetrating keratoplasty. Patient underwent keratoplasty, but we didn't send for corneal button biopsy. Fluoroquinolones are bactericidal broad-spectrum antibiotics that inhibit bacterial genetic replication through DNA gyrase and topoisomerase. Medication-induced corneal deposits have been reported with topical ciprofloxacin, ofloxacin, norfloxacin, sporofloxacin, gatifloxacin, tosufloxacin, but very rarely reported. Only one case is reported with moxifloxacin. That too, after stopping the drops, that crystalline deposits are subsided. But in our case, it's become irreversible. That mechanism may be, this is some factors which linked, there is unchanged in the pH level and tear film, corneal edema with impairment of corneal epithelialization and multiple drugs. Deposits can be confirmed by corneal biopsy. Topical steroid can cause corneal deposit, and corneal deposit can confirmed by light microscope with one COSA stain, electron microscope intracellular deposits, X-ray with energy dissipative particles. These deposits usually resolve with the cessation of drug. Conclusion, patients started on topical drugs should be on close follow-up, especially antibiotics like fluoroquinolones. Early recognition of these deposits, cessation of drug might resolve the deposits. Here the patient came late. Maybe that is why it's become permanent. Epithelial defect was there, and these deposits are like in epithelium up to mid-stromal lesion. Whatever previous reported in fluoroquinolones, they stop the drops, whatever medications, it is resolved. And it has become almost, it's normal, very few cases. But moxifloxacin is only, this is second reported case. And it has become irreversible damage. Thank you.
So no biopsy you said was taken finally? Biopsy
Didn't send.
was not taken?
Not taken. Usually this is usually clinical diagnosis.
No, agreed. But what will help in the future? It may
Yeah,
help
that
us
is what missed,
understand
madam.
if
That's
its
okay.
duration might
Okay,
help
that is what
or-
missed in this case. That.
And plus it was a combination drug, so
Yeah.
there will be some preservatives also. So it was not purely using moxifloxacin. I was more interested in the biopsy for that reason.
That is.
Not just pathological, but biochemical biopsy.
What
also
happened is,
should
madam, that went for other hospital. They have done the keratoplasty. They didn't send for. Later, we came to know that they didn't send for biopsy. That is what the become problem for this patient.
Because
So the patient was on steroid,
Yes, ma'am.
moxifloxacin,
Okay.
everything.
Yeah.
So how
This
do
is
you
maybe
know that
tear
it
film.
is-
Most of the time, previous reported cases, fluoroquinolones can cause corneal deposits. But moxifloxacin is not reported. Gatifloxacin and ciprofloxacin cases reported previously.
What was the dose? Because we usually
Second hourly, madam, 6 times a day. Yeah. And he didn't come for follow-up. First follow-up is finished. After next follow-up, patient came after 1 month when the vision is dropped. When first follow-up, vision was 6.9 with 6x. When he came for after 1 month, when hand movements, okay, then only the patient came to follow-up.
So was you using moxifloxacin for 1 month?
No, that patient usually second follow-up after 2 weeks will stop it. But patient didn't turn up for follow-up. Okay, thank you.
The next presenter is corneal thickness and an epithelial thickness distribution in the myopic South Tamil Nadu eye using SDOCT. Dr. V. Vedua Krishnan.
Good afternoon. I am going to present a study about corneal thickness and corneal epithelial thickness distribution in myopic South Tamil Nadu eye using spectral domain optical coherence tomography. Myopia or nearsightedness is one of the most common refractive error worldwide and poses a significant public health concern, especially in East and South Asia. The increased prevalence of myopia among children and adults is linked to genetic and environmental factors such as prolonged near work and reduced outdoor activity. So the accurate measurement of corneal thickness and epithelial distribution are essential for diagnosis and monitoring of various ocular conditions including myopia, keratoconus, dry eye syndrome, particularly in patients undergoing refractive surgery. So SDOCT has emergently high prescriptive non-invasive imaging tool allow detailed evaluation of corneal and epithelial thickness. My aim of the study is compare the corneal and epithelial thickness in distribution in myopic eyes among South Tamil Nadu subjects using SDOCT. The study design is prospective observational study for duration of 6 months. The study population is 150 eyes of 150 myopic patients aged between 10 to 40 years with manifest refraction spherical equivalent ranging from minus 0.5 diopter to minus 12 diopter. Inclusion criteria is age between 10 to 40 years and myopic is about minus 0.5 diopter to minus 12 diopter. Exclusion criteria is patient with keratoconus, history of contact lens wears, any current or prior ocular pathology other than refractive error, presence of eye disorder, and history of ocular surgery or trauma. Study basic investigation then corneal epithelials are measured using SDOCT. These measurements include total corneal thickness, epithelial thickness in central zone 2 mm zone, and epithelial thickness in 8 sector of paracentral zone from 2 to 5 mm referred as a ring 1, and epithelial thickness in 8 sector of mid peripheral zone 5 to 6 mm is referred as a ring 2. The patient was categorized into low myopia, moderate myopia, and high myopia. Data collections were performed in standardized manner. Difference in epithelial thickness between low, moderate, high myopia group are assessed, and correlation between epithelial thickness, patient characteristics such as age, center, corneal thickness, and intraocular pressures are assessed. Statistic analysis, descriptive strategies were used to analyze, summarize the data, including mean and standard deviation for corneal epithelial thickness. A comparison between myogroup or controlled ANOVA for continuous variable. Correlation analysis were performed, association between corneal epithelial thickness and other factors, and p-value less than 0.05 or significant. Ethical consideration was given. This table shows the demographic and clinical characteristic of study participant. This among equal distributions of population with higher male present is present, and this table shows a low wire. We collected 50-50 samples from each groups. This table shows us the corneal thickness and epithelial thickness in different myogroup. These tables suggested central corneal thickness is thicker in low myopic patient and thinner in high myopic patient. That is inversely proportional to them. Similarly, for central epithelial thickness also present. This suggests us next shows the corneal epithelial thickness distribution in different sectors. Among this, nasal impaired shows the higher thickness in low myopic patient and least thinner in superior quadrant. This correlation of corneal epithelial thickness with age and refractive error. The age is negative correlation. As the age increase process, the corneal epithelial thickness and the mean refractive spherical equivalent is directly related to the values. Discussion: non-uniform thickness of distribution of corneal epithelial thickness with nasal impaired sector being the thickest and superior cervical thickness. The patient with high myopia were found to be thinner epithelial layer compared to those with low or moderate myopia. Our studies found that slight negative correlation between corneal epithickness and age, which supposed to finding Reinstein et al. Therefore, that epithelial thinning occur with increase in age. Unlike uneven epithelial distribution suggests that clinical should contain regional epithelial thickness variation when they are planning for refractive surgeries. Thinner epithelium in high myopia possessed additional change for refractive surgeries, and thinner epithelium may contribute to undercorrection for post-operative complications such as epithelial growth. The study main focus on corneal epithelial distribution rather than total corneal thickness provides more detailed information that is clinically useful, particularly in screening of keratoconus and other pathological problems. Conclusion: individuals with high myopia tended to have a thinner corneal epithelium, and slight negative correlation was found between corneal epithelial thickness and age. No significant association was found between epithelial thickness, astigmatism, corneal vision, and IOP. The recommendation: understanding the distribution of corneal epithelial thickness is critical for optimizing clinical care in ophthalmology. Recognition of regional variation in epithelial thickness can improve detection of early corneal disease such as keratoconus before performing refractive surgery. Incorporating epithelial thickness measurement in pre-operative assessment could lead to better patient outcome in corneal surgery and management of refractive errors. These are my references. Sir, other studies and all, they didn't compare three groups. Recently, the Sankara et al. Had done studies among school pupils. They got tell that only prevalence. They didn't tell about reference. Sir. I have compared each low, moderate, and high myopic patients.
So, isn't this expected that the corneal thickness, the entire eyeball coat will become thinner as the axial length increases, especially if it's axial myopia?
Yes.
Scleral thinning is also known.
Yes.
So, it is already a known feature that all the coats of the eyeball will thin out. Have you assessed the per diopter change or something like that? That if they have 6 diopters, so much 10 microns will differ,
Yes,
or something like that.
That's only I compared.
So for every diopter, how much change of CCT is there?
No.
Yeah, so that makes it more significant because these are the patients who will go for LASIK.
Yes,
So that is the relevance of your study which you should highlight.
Next is Dr. Bhagla. Dr. Bhagla, Apurva Bhagla.
Is she present?
Dr. Preeti Singh.
Absent.
Good afternoon everyone. Today I am going to present paper on topic assessment of knowledge awareness when behavior practice regarding eye donation among inpatient. My co-author is Dr. Professor Shweta Walia and Dr. Niharika Arya. Corneal disease are one of the primary cause of visual impairment and blindness. According to WHO, corneal blindness is the fourth leading cause of blindness globally, contributes 6%. Corneal transplantation is the most effective method for treating and restoring vision to the patient having corneal blindness. Thus, public should be made aware of the importance of eye donation. However, the knowledge of this concept varies from person to person and depends on the culture. The study of the knowledge, attitude, and willingness toward eye donation among admitted patients of the tertiary care hospital is my aim. My primary objective is to evaluate knowledge, attitudes, and willingness for eye donation and educate about eye donation. My secondary objective is to record increased number of corneal type after educating during the study period of my tertiary care hospital and to make recommendation for steps to increase corneal retrieval. My study design is cross-sectional study. My study center is NY Hospital, Indore. Inclusion criteria is all patients admitted in NY Hospital with age group of more than 18 years and those who can read and write in local language. My exclusion criteria is not willing to participate in interview and subject who is unaware about eye donation. My study period is of 3 months with sample size of 250 and requirements are subject and their consent. Pre-test is semi-structured questionnaire with questions on demographic details, awareness regarding eye donation, willingness for donation, and source of information and reasons for denying eye donations. Here is a sample of my questionnaire. My study procedure to approach all the admitted patients in NY Hospital, explain the study which is going to be held, ask the subject to sign the consent for questionnaire, record the responses given by the subject in questionnaire, analyze the response, counsel and motivate the subject for corneal donation based on their responses. My results are male contribute 55.6%. Maximum number 45.2% of patients were found in the age group of 80 to 40 years of the age. 60.4% were belong to Hindu religion. Only 48.4% were having knowledge of eye donation. MY hospital was the main source of knowledge for the eye donation, which is 39%. Only 30% were willing for eye donation. The reason for denying eye donation is religion or caste that doesn't permit, disfigurement, and other. Others are family opposition, hinders the last ritual, and no specific reason given by the patients. Some other study also done, but not the exact one. Some are Kumar et al. In 2012 on urban slums in Bangalore with sample size of 300. Other is Okai et al. In 2006 on OPD visit patient in Nigeria with sample size of 250. And other is Priyadarshini et al. In 2013 on adult in rural area of Bangalore with sample size of 350. The knowledge percentage show variability across the different population with the highest awareness in rural area of Bangalore and the lowest in the Nigeria. The results from our study find in the mid-range. Willingness to donate eye is consistently low across all study with the highest willingness observed in our study followed by rural area of Bangalore and lowest in urban slums in Bangalore. Source of knowledge varies significantly with rural area benefiting most from health programs and camping. Hospitals were the main common source in both Nigeria and our study, while television was the significant in urban slums. Religion and caste reason and figure of disfigurement was the significant barrier in our study conducted in Bangalore, Nigeria, and rural areas. Our study indicated a much higher proportion of other reasons for denying eye donation, suggesting lack of detailed education, awareness, and understanding. So the conclusion is, this was the first study among the admitted patient. The data underscores the complexity of eye donation awareness and willingness and influenced by social culture factor and information. This study highlights the need for improved awareness campaign, education initiative to enhance knowledge and promote positive behavior practice regarding eye donation among inpatient or tertiary care center. Such efforts are crucial for increasing the availability of the corneal tissue for transplantation and addressing the gap between supply and demand in eye banking. Thank you.
So your sample population was inpatients.
This one?
The sample population was inpatients.
Admitted patient, yes ma'am.
Of which departments?
Of the whole hospital, which all those who are admitted in MY hospital Indore, we are counsel all those patients.
And including ophthalmology?
Ophthalmology also.
In your question is there. So in the question you are asking from the patient.
Yes, sir.
So you are not asking some social question why they don't want to donate, because somebody is, they are saying that in next birth they will born without the eyes.
Yes, sir.
Or so why they don't want to donate and why?
Whenever I approach the patient, my first question is whether they know about eye donation or not. So if they said no, so this is my exclusion criteria. I will exclude those patients and I will counsel them what are they, why they are not, first whether they are not know, but I will tell them what is that this is not the whole eyeball, I will take out only the thin transparent sheet, I will take out like this. Then still they are denying, then I will ask for why, what is the reason you are not allowing. So some people usually their families like caste in Muslim people, they don't allow. Some people think in next birth they will not get eyes like this, and some people is like they don't want to without any specific reason.
Was it an open-ended questionnaire?
Yes, ma'am.
It's a good study, so
Yes.
it's required.
Thank you, ma'am.
Dr. Devansh, is he here? If Dr. Prafulla hasn't come, I think this marks the end of the session. If any of the other speakers have come in, Dr. Apurva, or Dr. Shipra Sharda and Dr. Jyoti. None of them? Then I think we can have a photograph with the speakers.